Good afternoon, students. So, in two lectures, we covered the COPD from the lung system, and now in today's lecture, we will see about the pneumoconiosis. So, in the early 90s, this term was coined, and it is coined from the Greek word. As we know, pneumo means lung and conios means dust. So those people who are exposed to dust, and also those people who are exposed to organic and inorganic particles, you can say dust also, due to their occupations. But in recent scenario, this pneumoconiosis also includes the infections which are also caused by due to the chemical fumes and vapors. So what are the agents that causes lung diseases? Basically pneumoconiosis. So it has been divided broadly into 4 categories. It can be either mineral dust, it can be organic dust that can induce hypersensitivity, or the organic dust that induces asthmatic reaction or asthma, and the chemical fumes and vapors. We will see one by one the common things which occur. So what are the substances which comes under mineral dust? They can be coal dust, silica, asbestosis, beryllium, iron oxide, barium sulfate and tin oxide. So all these substances are included under the category of mineral dust. What are the substances that are included under the category of organic dust that induces hypersensitivity reactions? That includes the mold hay, bagases, bird droppings. These things will causes the hypersensitivity pneumonitis. And the substances like cotton flax or hemp and red cedar dust, they causes the asthmatic attacks. These are substances which induces asthma. And chemical fumes and vapors include nitrous oxide, sulfur dioxide, ammonia, benzene and insecticides. So this table is given in Ravi's textbook. And what are these substances and what they leads to? Difference what I have already described: mineral dust, organic dust, including hypersensitivity, asthma and chemical fumes. So in mineral dust, the most common diseases we observe is anthracosis, which is due to the coal dust. There are other spectrum of diseases also which is caused due to the coal dust. They can have varying from the anthracosis to formation of macules to progressive massive fibrosis. I will tell you in details. This is just overview. And they are mainly seen in the persons who are working in coal mining industries, particularly hard coal. And silicosis have the diseases varying from silica along with Kaplan syndrome. So can anyone tell me what is Kaplan syndrome? It is the combination of rheumatoid arthritis and pneumoconiosis. It is the combination of rheumatoid arthritis and pneumoconiosis. And these patients will have lung nodules. And they are seen on chest X-ray also. That will be covered in your clinical part, Kaplan syndrome. And they are what silica? Silica, from where it comes? Those persons who are working in metal casting industries, metal cast, sand blasting and hard rock mining, stone cutting workers. They will expose to silica particles and they will develop the silicosis. Another substance is asbestosis. They are from the mining workers again, and manufacturing and installation and removal of insulation, electric material, electric industries, insulating materials. That industries evaporates this asbestos like substances, and people who are working there, they exposed to this asbestosis and they will develop in a long duration course asbestosis. That spectrum again varies from pleural parts to the malignant counterparts like bronchogenic carcinoma to mesothelioma. So asbestosis is carcinogenic. Other rare things include beryllium, iron oxide, barium sulfate and tin oxide. But these things can be asked in multiple choice question, like stenosis is caused by, right? It is caused due to the tin oxide. Then siderosis is caused due to the iron oxide, and barytosis is caused due to the barium sulfate. So these things you have to remember because they can be asked in multiple choice questions. Other substances which induces hypersensitivity pneumonitis, organic dust includes the farmer's lungs caused due to the mold hair. Bagosis caused due to the bagaces, and bird breeder's lung or bird's lungs caused due to the bird droplets. Bicinosis is caused due to the cotton fibers, those persons who are exposed in cotton industries, right, raw cotton industries. Also red cedar dust, they induces the asthma, and chemical fumes, they induces the bronchial asthma to edema to acute respiratory distress syndrome to mucosal injuries to the bronchial mucosa. So we see normally there are particles in the environment also. What we breathe also, there are numerous particles. Normally everybody inhales, but not everyone will get the pneumoconiosis or lung pathological disorders, these interstitial diseases. So there is some aspect of genetic susceptibility also. That is one part. Another part, those patients who are smoking. So what happens? The normal mucociliary mechanism will be there. So what are danger particles, right? The terms come here. What are danger particles? So what size of the particles that will causes these diseases? So the particle size ranging between 1 to 5 micrometer. They are danger particles. So what is the spectrum? Those who are less than 1 millimeter and those who are greater than 5 millimeter. Micrometer, sorry, not millimeter. That is micrometer. So those who are larger, they will be trapped by the mucociliary mechanism because bronchial epithelium is ciliated. So whatever particles will be there, they will be trapped by the cilia, epithelial cells, and they will be destroyed by the macrophages. So bigger particles, they will be trapped and they will be removed. What happens to the particles that are less than 1 micrometer in size? They will reach till the alveoli, and they will penetrate the wall of the alveoli and they will dissolve in the blood, or they will be removed through the mechanism. So the size of the particle which ranging from 1 to 5, that are highly dangerous, that get engaged between the respiratory bronchioles till the respiratory alveolar ducts, and they will entrap and they will causes the reaction. So exactly general pathological pathogenesis of pneumoconoisis, what are the factors that will matter in the pathogenesis or that will contribute in the development of pneumoconoisis? First will be the dust retention, size of the particle, that particle solubility and their ability to cause cytotoxicity, then particle uptakes by the epithelial cells and activation of inflammasomes. So all these factors, they contribute in the development of pneumoconiosis. So what is dust retention? In dust retention, it also depends upon the concentration of dust in the environment or ambient air, what we inhale. That also matters. Suppose you see the air quality of Delhi and Rishikesh, you compare both air qualities. We generally see, or we say Rishikesh air quality is more pure compared to Delhi because there are more trees, the environment is nice here. So that means dust concentration in the ambient air. Another, duration of exposure. So for how long these people are exposed? Because if we are getting dust here also, that will be for a very small duration of time. But those persons who are working in the industries where there will be continuous exposed to silica, asbestos or coal workers, they will expose every day for minimum of 8 hours. Because working will be for 8 hours duration. So that also matters. What is the time bound concentration of that dust particles and effective clearing mechanisms? So is there any exhaust which are, suppose someone is working in a insulating industry, electric fabrications, you have seen cellotapes making and all that, electric fabrication industries, and they will have a small space or concealed space. So is there any exhaust there so that fresh air will come inside? So that also matters. Effectiveness of clearance mechanism. Also these clearance mechanisms means our respiratory, own respiratory. As I told you, those persons who smoke, they will have the less mucociliary clearance mechanisms, right? Because their cilia are damaged due to smoking. So whatever particles will be there, they will be trapped in the respiratory tract and that causes inflammation. Particle size, I already told you, danger particle size between 1 to 5 micrometer. Then particle solubility and cytotoxicity. So those particles that are highly soluble, they causes rapid injury. Because they will dissolve the cell membrane and they will adhere into the cell membrane and induce immediate cellular response. While those who are less soluble, they will stick up to the membrane, they will take time and they will induce chronic inflammatory response. Also, the pathogenesis depends upon the particle uptake by the epithelial cells. It allows the direct interaction with fibroblasts and interstitial macrophages to occur. Right? Whatever this dust particle, after breaking the epithelium, they will expose to the macrophages, and that macrophages induces the pathogenesis. I will show you the image afterwards. Then activation of the inflammasomes, different kinds of inflammasomes, and that amplifies the intensity and duration of the local reactions. So particles stimulate the innate immune response and activate the immune cells. It also evokes some systemic response, and as I told you, there will be some genetic predisposition also. Not each and everyone will get pneumoconiosis. So what happens exactly, how this leads to the proliferation of collagen productions and fibrosis in the lungs. So when multiple factors like smoking, occupational hazards of dust, and other irritants and toxin and viral infection. What happened? They will damage the respiratory epithelial cells or respiratory epithelium, respiratory mucosa. Other factors also contribute, that is genetics factor also. As I told you, there may be telomerase mutation, there may be surfactant mutation and MUC5B variants also. So all they leads to the persistent epithelial injury. Due to chronic exposure, these patients will have epithelial injuries. What it leads to? It leads to the activation of innate and adaptive immune response. And due to this activation of innate and adaptive immune mechanism, there will be activation of macrophages. And these macrophages, they will secrete the pro-fibrogenic factor. And that leads to the abnormal proliferation of these fibroblasts and collagen production. And that will be ultimately deposited at the site of injury and in between the normal lung parenchyma. That leads to the areas of fibrosis, because this fibroblast will be deposited at the site of injury. So first, today we will see coal workers pneumonia. Till now, this is general description about the pneumoconiosis. What are different types of dusts, organic, inorganic, causing hypersensitivity, causing bronchial asthma, is difference. What are danger particles, size ranging between 1 to 5 micrometer, and what are the factors that contributes to the development of pneumoconiosis, that is duration, clearance mechanism, all that things, right? And in pathogenesis, how this injured bronchial mucosa causes fibrosis. So now what happens in spectrum of the coal workers pneumonia? It is caused by the inhalation of coal particles. So the persons who are working in coal mining industries, they will develop this coal workers pneumoconiosis. They also contaminating have silica particles also, which favors the progressive diseases. These patients may develop emphysema or chronic bronchitis also. They may have history of smoking or may not. So in morphological, there is a spectrum which causes this coal workers pneumonia. It will be varying from simple anthracosis to the massive pulmonary fibrosis. So anthracosis is the most common form of coal workers pneumonia, and it is induced by the pulmonary lesions in the coal miners, and their lesions vary from 1 to 2 millimeter in size, or there may be some larger in size also, and they consist of carbon-laden macrophages. So if you see, there will be small macular lesions on the lung surface in these patients. In a long duration course, they may lead to the emphysema. If these patients have exposure for longer duration, 10 to 20 years, they may develop the massive pulmonary fibrosis. So I already told you, Kaplan syndrome, it is combination of rheumatoid arthritis and pneumoconiosis, and it is manifested by the intrapulmonary nodules, which appears as homogeneous and well defined on the chest X-rays. These nodular lesions varying in size from 1 to 10 centimeter. They can be bilateral and multiple. So in Kaplan nodule, there will be combination of silicotic and rheumatoid nodule, both. So this is the spectrum of coal workers pneumonia. In one spectrum, there will be asymptomatic cases. To the worst spectrum or towards bad side, they may have massive lung fibrosis also. Right? You can see here, this is a lung gross picture showing black dot like things. I told you 1 to 2 millimeter macules will be there, black. And these macules are nothing but carbon-laden macrophages, which are there, suppose you see histomorphologically. They are tiny black pigments scattered throughout the lung surface. Right? And moving on to next, there can be simple core workers pneumonia also. In that one, the size of that macules will be or nodules will be larger, right? Then and that can be palpable to non-palpable, and they are also containing carbon-laden macrophages or pink. This one, sorry, pink black pigment deposition. And in long duration course, these patients may have compromised lung function with massive pulmonary fibrosis. You can see this white septa in between. They are due to this is complete blackout lung, black lung with heavily pigmented, and there will be fibrous nodules, different. You can see these whitish patches. They are fibrotic nodules in the lung. So what you see in corresponding histomorphology or histopathological pictures, this is anthracosis. You can able to see there are destruction of alveolar spaces, few of them. Along with there is the deposition of this carbon-laden pigment or carbon-laden macrophages. The larger one, they might have the cell macrophages. Inside their cytoplasm, these are black carbon pigments. While in case of simple core workers pneumonia, there will be deposition of these black pigments with very minimal fibrosis. Right? There are thin fibrous septa. You can see there are thin fibrous septa which are there, which are demarcating these nodules. Simple. While in case of complicated core workers pneumonia, there will be massive fibrosis. There will be large areas of fibrosis and big septa which have demarcation, big nodules, and they will have decreased lung capacity. So lung has decreased capacity, they will unable to maintain the saturation, right? So higher magnification, you can see this is from progressive pulmonary fibrosis. These are areas of fibrosis with carbon-laden pigments. You can see there are some normal lung parenchyma in the upper part. These are normal alveoli, and there this area showing the destruction of the normal alveolar spaces. All these areas showing destruction of the alveolar spaces and areas of fibrosis with carbon-laden pigment. Right? So you have seen there are three spectrum varying from asymptomatic patients, that we call them anthracosis. They will have just small blackish discoloration on their lung outer surface. And they can have another spectrum will be core workers pneumonia. They will have some larger nodules or compared to anthracosis. And in long duration courses, there will be massive pulmonary fibrosis. So what are clinical features? These patients usually have benign course, and it depends on the stage of the disease. I told you in long duration course, they may have massive pulmonary fibrosis. So they do not affect the lung function in majority of the cases. 10% of the patients who are having core workers pneumonia, they develop into the pulmonary massive fibrosis over a period of 20 to 30 years. And it leads to the increased pulmonary dysfunction, pulmonary hypertension and cor pulmonary. Why cor pulmonary develop? Because there will be resistance to the blood flow in the lung. So due to that, there will be right ventricular hypertrophy that leads to the cor pulmonary. There is no definitive cure, symptomatic treatment or supportive care. And those patients who are having additional history of smoking, they should be stopped. And vaccination against secondary infection to prevent secondary infection, pneumococcal and influenza. Moving on to second entity. Till now, any doubt about core workers pneumonia? The most common form of pneumoconiosis, core workers pneumonia. Those persons who are working in coal industries, they will develop, right? We have seen three spectrum of this disease: anthracosis, simple core workers pneumonia, and massive pulmonary fibrosis, right? Anthracosis patients will be asymptomatic. In autopsy cases only, we will see their lungs will have the blackish discoloration. They are very small minute. In simple co-workers pneumonia, the lesions will be little bit bigger size, but also they are also non-symptomatic. But in case of patients who are having long duration course, they will develop progressive pulmonary fibrosis or massive fibrosis, and this 10% patient will manifest, right? So moving on to next entity, that is silicosis. First is co-workers pneumonia, now second is silicosis. So what is silica? Silica is one of the organic particle only, that is mineral dust, right? And that is there are two components which are abundant in the earth dust. They are silica and oxygen. And the pathogenic particle or pathogenic substance which causes silicosis is silica dioxide, that is SiO2, and that is combination of silica and oxygen. And this silica comprises some 59% of the earth dust, what I told you. So there are two forms of silica. I will tell you, crystalline and amorphous, right? And most of the symptoms or signs or disease of this silicosis is caused due to the crystalline form of silica, what we call the silicosis. Because these crystalline forms of silica, they induces the pro-inflammatory reaction in the lung parenchyma. And this is most common occupational lung disease worldwide, silicosis. And their incidence is 1 million workers are exposed to high levels of silica, estimated 1 million workers every year almost. The use of air handling equipments and face masks has substantially reduced the incidence of silicosis worldwide. So what are the persons they get silicosis? So those persons who are working in hard rock mining industries, right? Then persons who are working in stone cutting industries. Also persons who are working in foundry workers, that is they will melt some metals and they will prepare some metal articles, right? Also they will sand also, right? Glass working industries also, and there will be industries from this sand blasting. They will expose this high pressure sand on the metal surface in the industry. So there you can see the evaporated material, they contains silica. So remember these four: foundry workers, sand blasting workers, stone cutting workers, and hard rock mining. They develop the silicosis. So silica, it occurs in two forms, that is crystalline and amorphous. But more pathognomic and more dangerous is this crystalline form. That causes fibrinogenic effect. You can see their sharp edges, right? So they are not in name also, it has given crystalline, solid forms. So they will got entrapped in the epithelial surface and they damage the epithelial lining, and they induces this fibrinogenic reaction, what I told you in the initial general pathogenesis of pneumoconoisis, right? That macrophages activation secrete the pro-inflammatory and fibrogenic substances and leads to the proliferation of fibroblasts. And this non-crystalline or amorphous form of silica, it is usually less toxic. So the mechanism we are saying, the inhalation of the crystalline silica that interacts with the epithelial cells and macrophages, that leads to the activation of inflammasomes and release of inflammation mediators like interleukin 1, interleukin 18, tumor necrosis factors, fibronectin, lipid mediators, and reactive oxygen species. These reactive oxygen species, they are directly damages the epithelial cells, and that leads to the fibrogenesis and areas of fibrosis development at the normal alveolar spaces or at the level of respiratory bronchiole also. So remember these factors, interleukin 1 and interleukin 18. In silicosis, they develop in the formation of fibrosis. So how these silicas, they will kill these macrophages and this process amplified, or they will have repetitive process. So what happens after ingestion of these silica particles by the macrophages? The silica hydroxide groups on the particle surface to form the hydrogen bonds with phospholipids and proteins of the cell membrane. They form the bond with the cell membrane of the macrophages and they damage that cell membrane, and ultimately they kill the macrophages. The silica dioxide, they will have the bonds, they will have formation of the bonds on the cell membrane with the help of phospholipids and proteins, and due to that bonding the cell membrane will be damaged and there will be killing of macrophages, and this killing of macrophages leads to release of silica particles and fibrogenic factor. So again the silica particle will be released, that will again be trapped by another macrophage, that another macrophage, again it will be damaged. The process goes on, right? Repetitive process goes on. Along with that damaged silica particles, there will be release of fibroblast also, right? Fibrogenic substances that secretes the fibroblast. So reaction goes on, repetitive. So there will be release of the silica particle and there will be formation of fibrosis. That's why these people develops numerous fibrotic nodules. So this is the mechanism behind formation of fibrotic nodules in the silicosis. Understand? So what are the forms of the silica? So the crystalline forms includes, most common is quartz. The other forms, you have to remember these names, right? They can be asked. They are difficult, but you have to remember. So the crystalline forms include quartz, cristobalite and tridymite. And these are more fibrogenic because they causes more injury to the lung epithelium lining. And I already told you they leads to these secretions of interleukin 1 and 18 and leads to fibrogenesis. So the disease may continue to worsen even if there is no exposure or patient has stopped working to that area because he has already exposed. So initial exposure also in a long duration course can cause signs and symptoms in the patient. And these patients are more prone or susceptible to tuberculosis. Can anyone tell me why these patients will be more susceptible to tuberculosis? Right. Because the silica particle, they damages the macrophages. So those patients who are exposed to Mycobacterium tuberculosis, it is aerosol contaminated infection, right? That will be through breath only. So those patients who got this Mycobacteria, they will not be able to kill that Mycobacteria because the silica particle, they are already damaging macrophages. So they will get the infection from the Mycobacterium tuberculosis. That's why due to this breakdown or killing of these macrophages by silica particle, these patients are more prone to tuberculosis. Most of the times the pathology will give you the answers why these things will happen, right? These patients also, silicosis, have the risk of lung malignancies. Because if you have the chronic inflammation and repetitive process, there will be unregulatory growth mechanisms that leads to, in a long duration course, malignancy. So again, these silicosis can have the simple nodular silicosis or simple nodules formation, and they are most common form of silicosis. Otherwise, again, these patients can develop the progressive massive fibrosis, and their nodula are usually greater than 2 cm in diameter in a background of simple silicosis. In simple silicosis, this nodule will be small. They can be bilateral, and in progressive massive fibrosis, the size of the nodule can be as big as 5 to 10 cm, and they may have the central cavitations also inside their nodules. So what you will see on the chest X-ray of uncomplicated silicosis or simple silicosis, there will be enlargement of these hilar nodes, right? And in case of uncomplicated silicosis, has small round opacity of this hilar node, and they will have eggshell calcification. You can see this is the eggshell, and due to repeated areas of fibrosis, they will have calcification, and this hilar lymph nodes looks like the eggshell. That's why this question is again asked. Eggshell calcification of the mediastinal hilar lymph nodes is seen in, right? So this eggshell calcification of the hilar nodes, that is seen in silicosis. So chronic classical silicosis, the spectrum varies from the patient may have silicotic nodule in a long duration, while few of the patients they will have accelerated silicosis to acute silicosis. So chronic silicosis is most common form. They develop in a patients who are exposed to silicosis over more than 20 years of duration, and they will have classic silicotic nodules, right? And there will be silicotic nodules develop in the hilar lymph nodes, and there can be areas of calcification. You can see these round structures, eggshell calcification of these hilar lymph nodes. And disease progress to fibrosis of the upper lobe. They are mostly manifested in the upper lobe of the lungs. While in accelerated silicosis, those patients who are get heavily exposed in a short duration of the course. If you want to talk, you can go outside and have chit chat, right? Why you are disturbing to other people's? If that is important, you can go outside. I have not tell anyone to compulsory sit in my class. If you don't want to listen, you can go outside. You don't think so this is important for your syllabus, right? So in accelerated cases of silicosis, they will have the heavy exposure to the silica particles in a short duration of course. And there will be also presence of silicotic nodules. While remember one thing, in case of acute silicosis, there will be absence of silicotic nodules. You will not able to silicotic nodules in acute silicosis, or there will be very poorly defined. If there will be, they will not be well defined, right? They will be poorly defined if present. Again, this acute silicosis, it is caused due to the heavy exposure over a short duration of period to high levels of silica and small particle size, and they causes the picture similar to pulmonary alveolar proteinosis. So it mimics with the diagnosis of pulmonary alveolar proteinosis. So I already told you silicotic nodules are not formed in case of acute silicosis, and in microscopically they will mimic with alveolar proteinosis, and they will have the dense eosinophilic material accumulation inside the alveolar spaces. So in alveolar proteinosis also the similar pink eosinophilic material, right, that will be seen in microscopically. That mimics with these cases of acute silicosis. So this is, you can see, a lung gross image of the lung from patients who are having advanced fibrosis. So you can see these are nodule formation and they will have large areas of fibrosis in between, right? So they are bronchi, bronchioles, and you can see there is a white structure in between. They are large areas of fibrosis. You can here also see this pleura is thickened. So this is thickened pleura, right? Here also you can see this is normal pleura. Some part, right? Some part is normal here, silica. But you can see compare this pleural thickening with this one. So this is thickened pleura along with advanced fibrosis of the lung. Similar picture in pictorial diagram, you can see here initially these nodules will be pale in the color and they are usually in the upper lobe of the lung. And if cold dust exposure will be there in these patients, they may have blackish discoloration. And these nodules progress to the hard collagenous masses in advanced stages, what we call the silicotic nodule. This is another gross image from the patients of the silicosis having progressive pulmonary fibrosis. You can see this collection of dark pigments along with areas of massive septa formation, massive fibrosis. This is well demarcated lungs, right? These are septae, large septae, which are dividing this lung parenchyma into multiple septae. So this is fibrotic lung along with pigment, carbon pigment deposition. So what you will see in microscopically? So in microscopically, in a diagrammatic picture, there will be in center part, there will be areas of collagenization. That is due to the bundles of interlacting collagen fibers, right? And these areas of collagenization, they are surrounded by the inflammatory cells like lymphocytes, right? But these inflammatory cells are usually not extensive in amount. It can be sparse chronic inflammatory cell infiltrate also. Also, these may have the carbon-laden macrophages, and in between these one inflammatory cells and carbon-laden macrophages, there can be presence of fibroblast also. So in silicotic nodule, in central area, there will be areas of collagenization surrounded by the chronic inflammatory cells, fibroblast and carbon-laden macrophages. And this is the real picture, right? This is diagrammatic picture, and this is the real picture. This is H&E section from the silicotic nodule, right? You can able to appreciate central areas of collagenization surrounded by ill-defined, this one mild chronic inflammatory cell infiltrate. If you see on the higher magnification, there can be seen these black pigments, these macrophages containing carbon pigments. And you can see in the periphery, this is normal lung parenchyma, right? Everybody can appreciate this is normal lung parenchyma. You can see normal alveoli, right? They are normal alveoli. In four corners here also, this is normal. This is also normal lung parenchyma. And this is the silicotic nodule. So what are complications? So these patients, I already told you how they are susceptible to the tuberculosis, and rate of the tuberculosis ranges from 5 to 43%. These patients, about 5 to 43%, the patients will have silicosis along with tuberculosis. As I mentioned, the silica damages the macrophages and the ability to kill the mycobacteria is hampered, and that leads to the development of tuberculosis in these patients. Other than tuberculosis, what are other complications that will have? Again, these patients can have cor pulmonary due to pulmonary resistance to the blood flow and leads to right ventricular hypertrophy and cor pulmonary. There can be spontaneous pneumothorax, or these patients may develop scleroderma or collagen vascular disease due to immune response, and very rare these patients can have lung cancers in a long-standing cases. So in clinical features, the patient may have dyspnea initially, which is on exercise, and in long duration course when there will be lung fibrosis, they will have dyspnea at rest also. Patient may have cough with or without sputum, and they may have wheezing or chest tightness, which can lead to respiratory failure in lung fibrosis. Treatment, no specific treatment, only supportive therapy, and prevention is the cure using the mask at the occupational sites. So till now we have seen co-workers pneumonia and silicosis. So moving on to next entity, asbestosis. Right? Again, asbestosis is a family of pro-inflammatory crystalline hydrated silicates. They are naturally occurring fibrous minerals that are resistant to heat and corrosion, and that due to that one, as they are resistant to heat and corrosion, and they are due to insulation and fireproofing material. Where from they get insulation and fireproofing material? Automotive brakes and wallboard materials. The industries which forms these materials, these patients will expose to this asbestos. What are these industries? These industries which are dealing with the metal fabrication. We can see this metal fabrication, right? Steel gates and all that preparation on. This one, metal fabrication, building or construction workers. They will expose to asbestosis, and also workers from the milling. And this one, they are from the electric insulating materials, right? Electric wires, insulating materials. Those workers who are working that one, they will get exposure to asbestosis. So again, the asbestosis produces four major categorization of the human diseases. Again, that will range from benign form to the malignant. In malignant counterpart, they may have these patients may develop the long duration course mesothelioma or bronchogenic carcinoma. And in non-malignant part, these patients will have the asbestosis, which is due to the pulmonary fibrosis, and benign asbestos related pleural injuries or pleural response that can be varying from pleural nodules to the plaques to the effusion. So asbestosis is a pulmonary parenchymal disease, and it is marked by the diffuse interstitial fibrosis that is due to the injury to the pulmonary lining epithelium and parenchyma. Again, it's depend on the, in general we have seen all these mechanisms depend on the concentration of that dust material, their size, their shape and solubility of that material. So again, this asbestosis, they are again in two forms. We have seen in silica also, crystalline and amorphous form, while in asbestosis, they are again having two forms. One is serpentine and second is amphibole. So which is more dangerous? This is amphibole. They are more dangerous. Why? Because they are more stiff. Right? They are stiff. They are more stiff. So what they cause is, due to their stiffness, they got entrapped in the respiratory circulation. They got entrapped in the epithelial lining. And due to entrapment, they causes epithelial injury. And they penetrate into the epithelial linings and reach into the interstitium and causes fibrogenic effect and fibrosis. But if you see in asbestosis, the two forms, serpentine and amphibole, the serpentine form is most commonly used. And this is most common. 90% of the form is in the serpentine form. But more pathognomic is amphibole. Why they are less pathognomic? Because they are flexible and curved. So they can escape the air spaces and they can be trapped by the macrophages. They are likely to impact in the upper respiratory tract passage only and removed easily by the mucociliary apparatus. Understand? Two forms asbestosis, serpentine and amphibole. Amphibole is more pathognomic but less commonly used, and serpentine is more common and less pathognomic. So how they causes? This inhalation of asbestosis material or substance. After inhalation, they leads or interacts with the epithelial cells and macrophages and penetrate into the alveoli and reaches till the interstitium. And after reaching to the interstitium, they release the mediators like interleukin 1, tumor necrosis factor, fibronectin, lipid mediators, and reactive oxygen species, and fibrogenic cytokines. And after this release of mediators, there will be fibrogenesis, which ultimately leads to the interstitial fibrosis. The mechanism is same as we have described in the initial part of pneumoconiosis. Everyone acts in a similar way. Also, as I told you, the spectrum, these are more carcinogenic, right? These patients may have the carcinogenic effect. Asbestosis patients develop the malignancy like bronchogenic carcinoma and mesothelioma. So what are asbestos related diseases? In asbestos, this is again a Greek word which means unquenchable, right? And it includes group of fibrous silicate minerals that occurs as thin fibers. This chrysotile accounts for the bulk of commercially used asbestosis material, and amphibolites includes the different forms like the amosite, crocidolite, tremolite, actinolite, and anthophyllite. Remember these things. They are amphibole forms. They are different for pronunciation also, but you have to remember these are amphibolite forms and chrysolite forms. So usually again these patients in a long duration exposure course, they will have the lung fibrosis. That is due to the asbestos fibers. Histologically seen in the asbestos miners and miners and insulator industries persons or people who are more working in that industries. Asbestos fiber, they can be long up to 100 micrometer, but they are thin in size ranging from 0.5 to 1 micrometer, so their aerodynamic particle diameter is small. So they are deposited in the distal airways and alveoli, particularly at the bifurcation sites or alveolar duct side. And first lesion is an alveolitis which is caused by asbestosis. They can have bilateral disease with diffuse interstitial fibrosis, asbestosis bodies in the lung in the early stages, and which ultimately develop into the fibrosis. End stage diseases will have honeycomb appearance on gross morphology. We can see in initial course, benign course, in lower lobes, usually they affect the lower lobes. You have seen the silicosis, they will affect the upper lobe. This will affect the lower lobes. In early stages, there will be minimum fibrosis, while in late stages, they develop the cystic area, multiple cystic area, and ultimately that coalesce or get together they form the honeycomb-like appearance. But in early stages, there will be very minimal fibrosis at the lower lobes of the lung. So in a benign spectrum of the disease, these patients can have the pleural plaques to pleural nodules to pleural thickening. So pleural plaques, these are most common manifestation of asbestosis. They are well circumscribed plaques, right? You can see these are plaques, pleural plaques. They are well circumscribed plaques of the dense collagen, often calcified, and they are anterior and posterior aspect of the parietal pleura and dome of the diaphragm towards varies in size and shape, and they can be asymptomatic in patients without parenchymal disease. Suppose these patients don't develop this parenchymal disease, like the areas of fibrosis inside the lung parenchyma, they will be asymptomatic. They will just have pleural plaques towards anterior, posterior lateral sides and towards the diaphragmatic sides. and they rarely seen before the 20 years of exposure. So they are seen over a long duration of course. When the patients will have exposure for more than 20 years, then these patients will have the pleural plaques. So pleural thickening. So there can be pleural thickening also, right? The pleural thickenings are often associated with parenchymal diseases. So in plaques, you have seen in plaques they may have associated pulmonary lesions or may not. If there, they will symptomatic. In pleural thickening, usually these patients will have the parenchymal disease, and asbestosis bodies can be found in the visceral pleural side also, and they can cause symptomatic disease. So these patients may develop pleural effusion also, and that may persist for months or years. Due to damage to the pleural surface, there will be reaction, inflammatory reaction that leads to the formation of pleural effusion in the patients. They will symptomatic, they will have chest tightness, pleuritic chest pain, fever, dyspnea, and effusion may be bloody due to areas of hemorrhage at the site of reactions. So in long duration course, these patients may develop malignancies, right? And they first recognized in the 1930, an average latency period in patients of asbestosis to develop lung carcinoma is 20 to 30 years. And it has association of lung cancer with smokers and asbestosis in multi-palliative manners. Adenocarcinoma and squamous carcinoma both can occur. These patients are also prone for the mesothelioma. 80% of occur in the males exposed to the asbestosis at the workplaces and living near the mines. They will have the more common is the mesothelioma. Mesothelioma is the tumor derived from the mesothelial cells lining the pleural cavity. So the pleural cavity is lined by the mesothelial cells, and these tumors develop at this site of pleura, right, in the lower portion. It is not hard and fast in the lower portion, but they are arise from this lining of the pleura. Mesothelial cells that are lining pleura, they will develop this malignancy. This is picture is given in Ravi's. This is asbestosis related pleural plaques towards the diaphragmatic site. These are both lungs, and you can see these are pleural plaques. This is another image of the pleural plaques. You can see these nodules formation also. So there will be pleural plaques and nodules. So what you will see in asbestosis, again there will be damage of the alveolar spaces, and they will be replaced by the areas of fibrosis. And the classical finding or classical thing that you will see in histopharmacology is the presence of asbestos bodies. Right? So what are these asbestos bodies? They are asbestosis fibers coated with protein-rich iron material. Right? So where the iron come from? They come from the macrophages. Right? There will be degradation of the hemoglobin. That heme will be there in the macrophages. So as this asbestosis, they damages the macrophages. So due to that damage, there will be release of these heme pigments or ferritin, and that heme pigment that deposited on this asbestosis fibers, and that coatings leads to the formation of these asbestosis bodies, and they will have this beaded appearance, right? And they will form the dumbbell-like shape, right? Dumbbell-like bodies. You can see they are thicker at they are both edges. Here also, here also. In between they are thin. These are different pictures. These are all asbestosis bodies, right? These are asbestosis fibers coated with protein and ferritin material or heme material, right? Due to that one, they are taking color of this one, heme-like pigment also, right? Reddish. And they are usually dumbbell shaped. You can see they are larger towards the end side. So what are ferruginous body? Ferruginous bodies are other inorganic particles or fibers coated with similar protein iron complex, right? So you have to differentiate between two ferruginous bodies and asbestos bodies. So asbestos bodies will have asbestos fiber, while ferruginous bodies will have other inorganic particles. Remember, this will again ask me MCQs. Ferruginous bodies. So in clinical diagnosis of asbestosis, the patients in early symptoms will be insidious onset of breathlessness, which is on exertion, and these patients may have clubbing of the digits in few cases. There can be cough, wheezing, sputum productions are unusual, and if present can be contributed with the patients who are having smoking history. In clinical spectrum, there will be similar to any other interstitial lung disease, rarely appears fewer than 10 years after the first exposure, and they are more common after the 20 to 30 year or more longer duration. Dyspnea is usually the first manifestation where the patient presents, and the disease may remain static or progressive to the respiratory failure or call pulmonary and death. Treatment, no specific treatment, only supportive therapy. So moving on to other rare forms, that is berylliosis. Any doubts? You can ask. So berylliosis. So these are uncommon things. So berylliosis, these are pulmonary disease that follows the inhalation of beryllium. The material which is used in aerospace, industrial ceramics and nuclear industries, those people who are working in that areas, aerospace, industrial ceramics and nuclear industries, they will have this berylliosis disease. In pathology, there can be acute pulmonary pneumonitis or chronic pneumoconiosis. 10% patient progress to chronic disease and they may develop chronic berylliosis. The exposure may be minimal and brief, and microscopically these patients will have non-caseating granulomas and are distributed along the pleura, septa and bronchovascular bundles. They may progress to end-stage fibrosis, and these patients may have honeycomb appearance of lung also, and they are associated with increased risk of lung cancer. Berylliosis patients again will have increased risk of lung malignancies. So this is histomorphological pictures from the berylliosis. You can see there are presence of granulomas and they are non-caseating. Whatever you are seeing, this one material, this is areas of fibrosis. Fibrosis along with non-caseating granulomas, surrounded by inflammatory cells and formation of these fibrotic nodules. So talcosis. What is talcosis? They are due to the prolonged and due to talc dust. It is mostly due to the magnesium silicates. They are lubricants and in cosmetics and pharmaceutical industries. Those persons who are working in pharmaceutical, cosmetics and lubricant industries, they will develop this talcosis. They are associated with minerals such as silica and may contribute to the fibrotic changes. There will be tiny nodules to severe fibrosis of the lung. The spectrum of the disease can be from asymptomatic to fibrotic lung disease. There will be formation of foreign body granulomas associated with birefringent plate or talc particles. If you polarize, right, on the microscope, when you will polarize the slide, you will see this birefringent material, talc particles in microscopy. Thank you. Any doubt in pneumoconiosis? In today's spectrum, we have covered coal workers pneumonia, then silicosis and asbestosis, right? Asbestos patient, they are more prone for malignancy. They may have mesothelioma or bronchogenic carcinoma. It can be adenocarcinoma or it can be squamous cell carcinoma, right? You remember about asbestos bodies also and ferruginous bodies. Then in silicosis also, we have spectrum of the disease varying from asymptomatic to the progressive massive fibrosis of the lung, right? There are silicotic nodules also. In coal workers pneumonia also, is usually spectrum varies in anthracosis to simple coal workers pneumonia to massive pulmonary fibrosis, right? Any doubts? You can ask. Little water, please.